Welcome to Building Blocks, a telementoring series that is a part of Project First Line, CDC's National Training Collaborative for Infection Prevention and Control. In the AMA's work with Project First Line, physicians have expressed that there are significant challenges in facilities outside the acute hospital setting, places like behavioral health units, ambulatory surgery centers, and acute rehab facilities, to name a few. To help in this area, we developed this telementoring series, bringing in healthcare professionals from these settings with IPC experts from across the country. This session will focus on some IPC questions that can arise within outpatient dialysis facilities. There are some unique challenges in these facilities. They can be independent setters or owned by large corporations. They typically see many patients in a day in one communal area, and these patients have their blood streams directly accessed 3 times per week. Before we look at today's case, I'd like to remind everyone that the opinions expressed in this session are those of the presenters only and do not necessarily reflect the official position of the American Medical Association, U.S. Department of Health and Human Services, the Centers for Disease Control and Prevention, or the presenters' affiliated institutions. There are also some ground rules I'd like to highlight. This is an all-share, all-learn format, so judging is not appropriate. Questions are welcome and often lead to great discussion. Some areas in infection prevention need more research, and until then, talking through these details can help us find great and often novel solutions. But we want our language here to remain respectful. For those of you joining in chat and asking questions, please introduce yourself, highlight the state you work in, and your role in the healthcare system: physician, nurse, technologist, or other role. We want to tailor our answers to what's most helpful to you. And lastly, please do not put any protected health information in the chat. Just keep questions general. I'm Erica Kaufman-West, the Director of Infectious Diseases at the American Medical Association. I'm the physician lead on AMA's Project First Line grant, and I also maintain a clinical practice in Indiana. Now, allow me to introduce our amazing panel. Our presenters are Bridget Pfaff and Dr. Dana Mitchell. Ms. Pfaff has over 30 years of healthcare experience. She has been a pharmacy tech, pathology assistant, and infection preventionist before transitioning to the director role. She has been in her current role as Clinical Operations Director at Amplify Health by Gunderson for 13 years in Southwest Wisconsin. She currently supports acute and outpatient dialysis facilities, including a home program. She has a bachelor's degree in microbiology and her master's in biology. She is a member of the board for the Renal Healthcare Association and is proud of her work supporting the core curriculum for renal healthcare administrators. Dr. Mitchell is the CEO of Global Kidney Center in Houston, Texas, with extensive experience in the care and treatment of kidney diseases, as well as a background in emergency care. In addition to practicing clinical medicine, she currently serves as an advisor to nephrology groups, given her extensive experiences with managing small and large nephrology practices. She also currently serves as the Medicine Program Director and chairs the Nephrology Clinical Performance Committee for the Memorial Hermann Physician Network. She has chaired and served on a variety of professional panels focused on clinical performance, quality, and medical ethics. She also has the privilege of serving as the Group Medical Director for DaVita, covering facilities in Texas, Louisiana, Mississippi, and Alabama. In addition, she received the Exemplary Nephrology Practice Award from the Renal Physicians Association. Dr. Mitchell received her medical degree from Louisiana State University. She completed her internship and residency there as well. Her fellowship was done at the University of Alabama, Birmingham. Our subject matter expert today is Dr. Michelle Dahl. Dr. Dahl is a system hospital epidemiologist for VCU Health System and an associate professor of medicine in the Division of Infectious Diseases at VCU School of Medicine. She is the medical co-director of the Virginia Infection Prevention Training Center. Dr. Dahl holds a Master of Public Health degree from VCU and is a member of the Virginia Healthcare Associated Infections Advisory Group. Dr. Mitchell, I'm going to present our case and then have you address our first case question. A 46-year-old Hispanic woman has end-stage kidney disease and has been on dialysis for the last 4 years through a central venous catheter. She develops a fever at her last dialysis session to 102 degrees with shaking chills. Blood cultures are drawn at the facility, and she is sent to the nearest emergency department for care. She is admitted and started on antibiotics. 12 hours later, her dialysis blood cultures are positive for methicillin-resistant Staphylococcus aureus. Dr. Mitchell, how common are bloodstream infections in dialysis patients?
So based on the CDC Vitals report, which looked at data from 2017 to 2020 from the Emerging Infections Program, it shows that dialysis patients are actually 100 times more likely to have bloodstream infections than the general population.
And in that vital signs report, were there any racial or ethnic differences that really stood out to you?
What stood out to me was there was an increased proportion of infections in Hispanics and African Americans. They don't delve in because this is really new data. We don't understand completely why, but looking at it, it seems like some of the social determinants of health are impacting that. It looked at infections being more frequent in patients who had multiple family members living in the home, for patients who had lower access to care. The lower access to care makes sense because you would think those patients, if the access to care is difficult, then they tend to have catheters in for longer because then they're not getting access to vascular surgery in a rapid manner from getting catheters placed. But those are two of the things that really stood out. So I think as we continue to hone in on these social determinants of health and how it's impacting care for our patients, we'll probably start to see more why these infections are increased in these populations, and then help us learn how to mitigate that as well.
And as is so often the case, I think that being aware of the discrepancy is the first step, right? Knowing
Yes.
that there is an inequality out there. And then it's going to take some time to take that step back and say, okay, we see that this outcome is different. Now let's look at why, because that data was based on sort of that 10,000 foot view of just Medicare data. But let's sort of get into the weeds a little bit and figure out why do these populations seem to be at higher risk, and what can be done then as the next step to help decrease that infection risk in those populations.
Correct. We have lots of tools. We educate the patients pretty frequently about things to do and not to do when they have central venous catheters. Obviously, we're trying to lean in significantly on getting AV accesses placed and bypassing the need for catheters altogether. But in some populations, we know that's not necessarily realistic. So understanding that data will help us fine tune our toolbox of what we can deliver to the patients, as well as the dialysis facility staff, on how we can decrease the risk of infections for patients who require central venous catheters.
And I think you bring up a great point. I mean, we usually think about infection prevention specific actions like hand hygiene, but infection prevention can be much broader. You can talk about vaccines, you can talk about patient education, as you pointed out, and those are still within the scope of infection prevention. And in this case, we want to dive a little bit more into the dialysis access type. So Dr. Dahl, does it really make a difference what type of dialysis access a patient has when it comes to the risk of bloodstream infections?
Yeah, so there is a difference in the risk. Certainly, there is some risk for all of the patients who are getting hemodialysis just because we are accessing the bloodstream each time that there is a session. But we do that under these aseptic conditions. And so in theory, we do a lot of prevention at that site. The catheters, in contrast to some of the other methods of access, are in place 100% of the time. They are essentially a conduit from the external outside world into the bloodstream. And so it is a path where bacteria can traverse that and enter the bloodstream. They're not supposed to. There's some additional risk with the catheters. Bacteria also, we know likes to stick on prosthetic devices, whatever that may be. And so the plastic is just a really good, or the materials of those catheters are really good media to support colony growth of bacteria that persist in that space.
Thanks for that. I think that when we talk about dialysis access, these dialysis patients have a lot of touch points within the healthcare system before they actually get to that dialysis center. Dr. Mitchell, what do you think, or who do you think should be talking with patients about access type, and how do you broach that topic with your patients?
So I think obviously as nephrologists, we own talking to dialysis patients about access, particularly when we get to the progression of CKD. However, we found it much more successful in terms of getting accesses placed ahead of time if we involve the primary care physicians in that conversation. So what we try to do is, impart to them how important it is for patients to get accesses early to decrease the need for central venous catheters for dialysis. Yes, there are some patients who require catheters because of other access issues, but if we can mitigate that and decrease those numbers, then we can decrease the rates of infections. One of the things I wanted to add to Dr. Dahl, we talk about, the dialysis facility and the techs, et cetera, accessing it and using aseptic technique. But one of the things we have to drill home to patients repeatedly is when you have a CVC or a central venous catheter, taking showers, you're not at liberty for that because getting those access is what does increase the risk of infection as well. And many of them, although they see catheters as a quote unquote easy access because they're not being cannulated repeatedly, they don't understand the lifestyle modification that also needs to go along with that.
That makes a lot of sense. And I think especially when patients come into the hospital and need that acute dialysis line, sometimes those catheters, they get placed and then they get tunneled and then they're just sort of left in. But it seems that it's sort of everyone's responsibility, every physician that the patient interacts with, to talk about access and how that central venous catheter might not be the best option for patients. Have you seen, because you practice in sort of the southern part of the United States, have you found in your dealings with all the various sort of locations there, is there a difference in which patients are able to have access to a vascular surgeon, for example, or someone else that might be able to swap that central venous catheter out for a fistula or a graft?
So in certain areas, it is a difficulty where they do not have access to vascular surgeons readily. Because I practice in the city of Houston, we do have the opportunity to have access to different surgeons and to multiple surgeons in terms of getting patients in a timely manner to get access placed. One of the nuances, though, with working with our vascular surgeon colleagues is the Fistula First initiative was born years ago, and we all focused on getting AV fistulas placed, but we've learned that in the KDOQI guidelines have been updated to reflect that we should look at each individual patient as their own life plan. So if the patient is elderly, if they've had multiple issues with access or have really small blood vessels, we may need to look at that patient a bit differently and not just focus on getting an AV fistula. Rather, the AV graft may be a more appropriate access for that patient as well.
No, it's a good point. We don't want any patient to feel, that their type of access, that they might not have the ability to get all of the different options, that if they're sort of in that situation where a central venous catheter is maybe their best option, we don't want to sort of vilify that or make them feel badly about that. Some patients, their anatomy and medical situation just requires that. And I always, as a non-nephrologist, forget about peritoneal dialysis as an option for patients as well, instead of the hemodialysis.
Correct. And that's why when patients have the benefit of seeing a nephrologist prior to the start of dialysis, they are educated about all modalities because we do focus on trying to give patients that option for home therapy. But that being said, we talk about seeing them before. I think nephrologists have been doing a great job as well for patients who crash into the ER, meaning they've never had a touch point with a kidney doctor before, of educating those patients about the ability for home, because we are able to do urgent start PD in the hospitals as well.
That's amazing. I think education and communication, as with most of medicine, really goes a long way, especially for patients with complex medical problems. Let's go on with our case. The patient is treated at the local hospital. She gets her antibiotics, catheter is removed, infection clears, and then the tunneled catheter is replaced. She's eventually discharged to finish her antibiotics infusions at her dialysis facility. Ms. Pfaff, I'd like to ask, what is required of the nurses and techs in that dialysis center to safely prepare a patient for dialysis?
Well, I think we have the same screening questions we're asking everyone all the time, regardless of this infection and evaluation, that pre-assessment for dialysis of, are they ready to go on the equipment, and is it safe to put them on the equipment? Infection prevention wise, there's not going to be anything we do differently for MRSA, much different than hepatitis B that has its own little cadre of tools that we have to follow. And it's spelled out very clearly in the conditions for coverage for dialysis that the standard precautions that we're using with a face shield, a jacket that's fluid resistant, and gloves, we're doing this for every patient. And much because as you look and see what the center looks like, these patients are close together. They're commingling in the waiting rooms. I think, you're getting their weight. They're passing by each other. They're very close to each other. MRSA isn't going to be spread the same way in the dialysis facility. It's the hands of those healthcare workers, and it's my job as the administrator, together with the medical director partners, to be looking at practices. Are we observing people who are touching that equipment? Those machines are so close together there. It's real easy just to reach over and silence an alarm. And is that going to put that other patient at risk? Thinking through that pod type setting and looking at how you segregate clean and dirty, and can you even clean it, or have you hoarded every supply you might potentially need for the next week onto that cabinet, and evaluating the environment, making it clear with a line. This is where my dirty face shield can go. Again, regardless of if it's MRSA or some other wimpy staph bug, I guess you could say, to say it is something that we should be looking at these practices 100% of the time. And then there's, again, that whole other cadre of steps to take if it's hepatitis B. But this is something, the picture of, all the gloves, I might need those gloves like for the next 3 months in the dialysis treatment area, versus having a box of the most commonly used sizes and making it just a much friendlier work environment and less chaotic. So infection prevention is a little bit of that piece of looking at the environment that way, and just a little bit of how do we reduce the stress in the environment by minimizing that risk. So that would be where I would focus for infection prevention, and doing the same things, the hand hygiene, offering that to patients before, during, and after they're using a fistula to access. We have some great education here for those patients to focus on, how do we redo that? You don't have to have anything glitzy or glamorous to educate your patients. It can be a simple conversation. Dr. Mitchell talked about the importance of that partnership with the interventionist, with primary care. All of those conversations, if we're, the answer I think gets to be that everyone is a part of this for infection prevention. And we each play that role in the facility when we're looking at a pod-like setting, auditing practices and building a culture of safety, and making it okay to say, now, I'm sorry you didn't do your full access washing before you came back. Maybe a patient can't stand at the sink that long. What is their specific care plan, and what education is being done for that patient? I had a facility at one time where the patients were asked to wash their fistula arms, but they had to bend themselves in a much different crinkled way. We put in a new sink that had a bigger basin and just made it easier for those patients to perform their fistula and their access hygiene. So the answer is all the time, every time, and it's all of our job for infection control, and assuring that we're following through on the importance of layering education over and over again for these patients.
I love that all the time, every time mentality, because it really does only take one breach in these protocols in order to introduce an infection directly into the catheter or someone's bloodstream. And I was really impressed when we first started talking about this topic, how much patient education really happens, before dialysis, but even sort of every time that they come into the center, the interactions with the techs, the interactions with the nurses, to really sort of reinforce the importance both ways, from the sort of staff to the patient, but the patient back to the staff, of making sure, did you wash, did you use hand hygiene, is everything the way it's supposed to be all the time, every time. I just think that's a great concept to impart. Dr. Dahl, we are talking a lot in this session about MRSA, which is such an important infection in dialysis patients. But obviously there are other infections out there. And one that we deal with on a yearly basis is the respiratory viral season. And so I was curious, what can dialysis centers do to reduce the risk of infection? As we saw in some of these photos that Bridget shared, these are patients that are very close with each other, very close with the nurses and the techs for multiple hours, several times a week. So is there anything that can be done to reduce the risk of spreading viral respiratory viruses through that time of year?
So I think we can prepare for the season that we know is coming. I think we, on the same line as we're preparing and we're doing education up front, there are opportunities to do the education around the vaccination and why that's important, and what that, not only what that does for the greater good, but I think especially important to emphasize what that does for the patient or staff member who's getting the vaccine, and emphasize those positives as well. And then also, there are some special challenges in this setting, as we saw in the pictures. Everything is very close together. Very difficult to, especially if, as the community rates increase, if you have an outbreak in the community, you can expect that you will see that coming into the dialysis center as well at some point. We do have some flexibility around what we're doing with masking, and it depends, and different centers can have different kind of procedures and policies, and it really is dictated by what we see going on in the community and what's going on in the center itself. So certainly, if you are experiencing an outbreak situation, you may decide, similar to what we did in the COVID-19 pandemic, we're going to do universal masking. In the absence of something like that, often just emphasizing that respiratory etiquette of covering a cough, for your team members not to come into work when sick, to really take those days to recover at home before coming back in, and working to decrease the chances of transmission in that space. So I think there are some special challenges certainly for this area, but there are things that we can do to prepare. And then there are some things we can do to mediate those risks during the worst of these seasons.
Bridget, I'd like to sort of pose the same question to you, sort of in your work on the ground, frontline in those dialysis centers. What have you found that's helpful during respiratory season?
Well, I think Dr. Dahl hit on everything appropriately. You have to pay attention to what's going on, what's out there right now. We have published a couple of documents during the pandemic about transmission, both proving that transmission didn't occur within our facility, and then saying, oops, this did happen here, and how did we monitor, and what are things we reinforced. And when we went back to look at practices when the actual transmission, we were fortunate to have great support in our research lab of doing genomic testing of the samples from our patients during the pandemic, and certainly making those articles available as reference tools to the individuals who are participating in today's event, to say, oh yeah, that makes sense, that when the patients were taking their mask down when they were in the communal area of the waiting room, that's most likely where transmission was occurring. So as Dr. Dahl mentioned, there are times that we're going to be doing some line listings, and we're going to be talking through, whether that's through the COVID pandemic or through influenza and that ongoing experience. Have you built relationships? And I'm fortunate, I'm part of a hospital-based system. I've got a facilities team that can tell me how many air exchanges are in my building. If you're leasing space in a freestanding dialysis facility, how do you find that out in your facility? And are you the one who has to be the expert on making sure you have the right number of air exchanges? So many of the things highlighted in that tool and that we've incorporated in the project that was mentioned earlier with the Renal Healthcare Association and our core curriculum, many of those tools are readily accessible within that tool to get facility leaders aware of how to navigate in the event of an outbreak.
I think, as we all know, planning ahead is always better than scrambling after. So it's, as Dr. Dahl said, we have the luxury of knowing when respiratory season starts and planning ahead of time, making sure patients get their vaccines, they have the education about that, and doing everything possible to try to mitigate some of those risks. Well, I just want to say thank you to everyone for joining us today. Thank you especially to our guests for sharing their input and insights. Dialysis patients are at a much higher risk of bloodstream infections than the general population. And it's been really interesting to look at all of the different places where we, as caregivers within the healthcare system, can intervene to lower that risk. We hope that you learned a little more about how to look at IPC and dialysis centers, along with some resources you can use in your practice. We hope to see you again at our other building block sessions.